So Dr. Ahmed, Dr. Aheba, thank you so much to the Kuwait Gastroenterology Association for inviting me here. I'm really thrilled to be here. You've given me a difficult talk, not one of my usual, so I've had to sharpen up a little bit, so thanks Heba for that. And I will touch a little bit on inflammatory bowel disease because it's nice to know that when DILI is concerned, the IBDologists give us some work. But actually, why is DILI important? It's important because from a clinical trial standpoint, it is the single greatest thing that kills drugs in clinical trials, and it's the single greatest thing that causes the issue of a black box warning. It also contributes considerably to acute liver failure. And as background, we're all used of the idea of some drugs having a predictable toxicity, dose-related. We think of paracetamol and the breakdown products. If you take enough of it, you get liver toxicity and it's reproducible. What causes us much more difficulty is the idea of unpredictable, idiosyncratic drug-induced liver injury. It may or may not be dose-related. The latency, the duration of time in which patients are exposed to it is variable, and also it is lower in incidence. So when you see a patient with DILI, the Council for Organization of Medical Science has classified our approach to DILI in terms of categorizing according to hepatocellular, cholestatic, or mixed. And you can see for yourselves there the approach that if it's predominantly ALT, AST based with low cholestatic markers, hepatocellular, and then if it's less than 2 with predominant alk-phos, it's cholestatic and mixed in between. Now, Hy Zimmerman was a US-based hepatologist who has given his name to what we describe as Hy's Law. And this was adopted by the Food and Drug Administration in the United States because Hy Zimmerman recognized that if you had a bilirubin greater than 3 times the upper limit of normal, and AST/ALT more like greater than 3 times the upper limit of normal with a low alk-phos, you had a very high likelihood of having severe hepatitic DILI. The FDA have subsequently modified this, but to a lower bilirubin level. But it is important because if you have these types of events in clinical trials, then in real life, when you let these drugs out in post-marketing, you have a high risk of death and liver transplantation. And because of the adoption of this, there are very few drugs now beyond the 2000s that have actually had to be withdrawn in post-marketing hepatotoxicity. They have allowed drugs to go to market where they have taken a calculated risk. And these are some examples of some drugs that have gone to market but subsequently been withdrawn. Those of us that are old enough in the audience will certainly remember triglytazone and some of these other drugs, but these have since been taken off. This was one of the drugs that was going to be potentially really useful in pulmonary hypertension. Now, as hepatologists and gastroenterologists, the other group of drugs that we are increasingly having to consult upon is the group of agents now used as immunotherapy with a degree of predictable hepatotoxicity, but as gastroenterologists, you're also seeing inflammatory bowel disease. And the difficulty for us as hepatologists and gastroenterologists is now our oncology colleagues believe they can manage these complications, aren't already trying to manage them before they send them to us. So they will have given steroids, they may have given anti-TNF therapy. From a pathogenesis standpoint, why do people evolve with DILI? Well, some of it relates to the actual medication that people are exposed to, drug itself, the host age, polypharmacy as patients get older. Women seem to be more likely to get hepatocellular DILI. And of course, there are some there are polymorphisms in HLA and others that are important in terms of susceptibility. And if you have pre-existing liver disease, this also makes you more likely to have or acquire DILI. And this DILI can occur either because of the drug itself, or metabolite, for example, thiopurine therapy. We're all familiar with managing azathioprine toxicity and measuring levels, looking at the metabolites and dialing down the drug according to these metabolites. Other breakdown products can remain in the system for other drugs and you can get an immune response. And this is how we believe DILI evolves. So to illustrate the talk, I've included some cases. This is a 25-year-old man. He was unwell for 2 weeks, and he had 5-day exposure of flucloxacillin for an ingrown toenail, and he denied any other over-the-counter drugs. And when he presented to his primary care physician, he had a bilirubin level of 185 with a peak that went up to 600. He had transaminases, 201, with a relatively low alk phos. So we'll do the calculation, and we calculate that this is hepatocellular jaundice, and this is important because it puts him into a category of risk long term. Now, we also classify patients according to the severity of the bilirubin level. So bilirubin levels less than 2, mild, greater than 2, and of course, once you start developing coagulopathy or ascites, this puts you into a much more severe category. Some tools that we can use in clinical practice is the RUCAM score, which has a number of parameters that are looked at: the relationship in time with the drug, the course of the drug, other risk factors like age, other drugs that are polypharmacy, and other non-drug causes and re-challenge. And of course, you can calculate a range of scores from this. More recently, you have a tool that you can access online, and it's actually very useful. You can access it on gihep.com. It's the RECAM, and it's a modification of this older system that takes into consideration exclusion of other agents. So coming back to our case, we took a little bit more history from the patient, and actually he said, oh, I go to the gym all the time, and he was taking some bodybuilding supplements. And we see in clinical practice these in isolation. It can cause people to be jaundiced, to acute hepatitis, and in some patients they can even get chronic disease or loss of bile ducts. And we also know that if patients take these longer term, they can also develop hepatic adenomas and indeed rarely carcinomas. Now, in contrast, flucloxacillin is a much more common drug with toxicity in older patients, more likely to get toxicity with longer duration of exposure, and this has clear immunogenic activity that is truly related to the HLA genotypes, which can increase the likelihood of drug toxicity by 80-fold. But in our patient, what we actually see is a bland cholestasis rather than a hepatitis, and of course this makes it much more likely, particularly when the HLA genotypes are negative, that this is a more drug-induced liver injury from the anabolic steroids that were found ultimately to be in this product. Now, what is also important, and I'll touch on this again later in my talk, is that the genes that regulate the bile salt export pumps, multidrug resistance protein 3, on the edge of hepatocytes are increasingly recognized as being important in patients who develop drug-induced cholestasis. And increasingly, this is the phenomenon that causes patients, they're either heterozygote or homozygotes for mutations in these bile salt export pump proteins, so that when they get exposed to a drug, the pumps get stunned and then the components of bile are not in a position to be either excreted from the hepatocyte or put into the bile. So when you experience patients with very high bilirubin levels, 500-600, think of the bile salt export pump mutations, and we'll talk about this a little bit later. So how common is DILI? Well, in population-based studies, it varies. It varies from Iceland, where it is very high. But remember, Iceland has a very discrete population, doesn't have a great degree of immigration to Iceland. People don't follow the ice particularly, they follow the sun. So the population is very homogeneous. In the United Kingdom, for example, the incidence is less, but where it is, what we still see is a very considerable amount of patient volume that ends up in hospital as a direct consequence of drug-induced liver injury. So of 53 million, about 0.5% of them relate to DILI. Now, a lot of the really good information that we have obtained comes from the Dylan network in the United States, and this is one of the key studies from the Dylan network. And in fact, what we know from 900 patients collected in 10 centers over a number of years, that men much more likely to get cholestatic DILI, women more likely to have hepatitic, and the reality is that pre-existing liver disease adds a greater likelihood of more severe liver injury and greater mortality in that situation. And the other key observation from that study is that if you get cutaneous reactions or DRESS syndrome in conjunction with your DILI, the outcome is much more likely to be fatal. And the other really key piece of information is that patients exposed to longer durations of drug are also far more likely to evolve into a chronic DILI than patients who have a short exposure. So what are the real culprits these days? Well, from this study you can see that the greatest two categories are antimicrobials and herbal and dietary supplements. I've touched on the bodybuilding and we'll touch on those again. But if you look on the left-hand side of your screen, coamoxiclav, isoniazid, the top 10 individual drugs for DILI in the United States tend to be antibiotic related that are commonly prescribed. And that's 62% of the whole game, herbal and dietary supplements. And this is data from Iceland, and if you actually look at it again, you can see that it tends to be antibiotic therapy, a little bit of therapy for inflammatory bowel disease, autoimmune hepatitis. So this is very important. So looking at the US database, there are significant consequences to DILI. Unquestionably, for hepatocellular DILI, the latency can be actually longer. Cholestatic DILI, latency shorter. But if you look at the risk of fatal injury or need for liver transplantation, it tends to be higher with the hepatocellular, but more long-standing injury associated with the cholestatic pattern of disease. Now, we've been talking about IBS and the patients that are coming taking pages full of supplements, lots and lots of over-the-counter remedies, vitamins, God knows what's in them. So if you follow the prevalence of DILI related to herbal and dietary supplements, this is a Spanish study, and what you can see is that the rate and the prevalence of these agents, both bodybuilding supplements and non-bodybuilding supplements, the rate of DILI is going up considerably with these. Back in 2009, it was more than £500 million worth of sales in the United Kingdom, and that has almost certainly gone up. What is also worth mentioning here is that the type of injury or the severity of injury with the different types of agents is slightly different. The bodybuilding agents more likely to get cholestatic. It's all men predominantly that are taking these agents, as you would expect. Apologies, it seems to have jumped ahead. Yeah. Jumped ahead. It tends to be men that are taking these agents. And what I would say is that if you look at the time to resolution, particularly with the bodybuilding supplements, it tends to be months. They will stay yellow for many, many months, and this is important in clinical practice. If we also look at the prevalence of these agents in Iceland, you see the herbal remedies also have been fairly high. The key things in terms of messages are that women, as I've said before, more likely to have had a hepatocellular DILI, men more likely to have cholestatic DILI. Age is important, so augmentin, nitrofurantoin, more likely to occur in older patients, younger patients, anti-epileptics and tetracyclines. Think about polypharmacy with anti-TB treatment, and of course, if the longer patients are exposed to these drugs, the more likely they are to come to harm. Chronic liver disease enhances the risk, and genetics, this is something that is really important. If you look at the age and the risk of DILI, what you automatically see is that, apologies, the risk of DILI goes up as people get older, and also what happens is the risk of polypharmacy goes up. They're exposed to many more prescriptions as individuals as people get older, 7, 8, 9 drugs at a time. Now, I mentioned the genetic issues related to bile salt export pumps. When you find patients with bilirubins of 6, 7, 800 after the exposure to drugs, often what you will find is that they have mutations in MDR3, family histories of cholestasis or pregnancy, family history of FIC1 or itching on the oral contraceptive pill. If you find these patients, actually one of the treatments that we are increasingly doing with these is placing nasobiliary drains. It shortens the duration of jaundice, and it also improves the itch really quite dramatically for them. A second case, quickly, a lady, 62-year-old, AST and ALT elevated, smooth muscle antibody positive, stigmata of chronic liver disease and cirrhosis, and a history of nitrofurantoin exposure for a year. And what this is, of course, you'll all have seen this as drug-induced autoimmune hepatitis, particularly associated in women who are on long-term prophylaxis for urinary tract infections. You biopsy these patients, often they will have many of the features associated with autoimmune hepatitis, and unlike regular DILI, these patients will generally need long-term treatment. Of all the autoimmune hepatitis, about 10-12% of all autoimmune hepatitis represents drug-induced, and this is present in all of the registries. They're often cirrhotic, they will often have nodules, they'll often have plasma cells and disarray in their biopsies, and you treat these as though they're classical autoimmune hepatitis with reducing doses of steroids. Similarly, in the inflammatory bowel disease patients, you will see an acute episode of hepatitis, and actually if you give these patients a short course of steroids, it tends to make things recover, but they don't tend to relapse. I was going to briefly touch on nivolumab or PD-1-induced hepatitis, and this is something that you will come across. You will see these patients increasingly from your oncologists. These patients are different to autoimmune hepatitis. The transaminases go into the thousands. They will already have been pre-exposed to corticosteroid therapy. And what I would say is Be careful because a biopsy can be helpful. There are variants that cause inflammatory disease. There are variants that actually cause bile duct-related issues. So these patients need biopsies. They will need augmented immunosuppression, and if they occur, they can't have their chemotherapy again. I'm going to skip through the last thing, but just to say you will occasionally see patients who develop acute liver failure, high bilirubins, high transaminases. Once they develop encephalopathy, these patients need liver transplantation. Steroids are no use in acute liver failure other than very rare instances where there is no encephalopathy and established coagulopathy. So in summary, DILI is common. I could probably talk for hours. Think about it. It's a diagnosis of exclusion. Steroids are helpful in some patients, but not helpful in acute liver failure. And watch out for patients who have coexisting genetic mutations, because these are truly the patients that can benefit from the new treatments like IBAT inhibitors or nasobiliary drains. Thank you so much.